Hello and welcome to BoneUp, the podcast all about bones, how we make them, why we break them, and if we fully understand them. I'm David Armstrong.
Hi, and I'm Richie Abel. And over this series, we're going to be exploring osteoporosis, bones, what we know and what we're yet to discover. And we hope you will join us on the journey.
So, for anyone keen to learn more about our infrastructure of calcified collagen, this is BoneUp. Hello and welcome to a very special episode of BoneUp the podcast. We're live again, Richie. We're here in Liverpool and we're at the European Calcified Tissue Society meeting.
Yeah, it's wonderful to be here. It's a really great conference. I've been a couple of times in the past and there's always really good talks. And I was lucky enough to study for my PhD in Liverpool, so it's nice to be back to my alma mater and come to a city that really still feels like home.
That's great, and a big thanks to the ECTS who have been very welcoming and supportive and indeed proactive about supporting us with the podcast here, and indeed thanks to the people who've just come up and spoken to us and are keen to take part. So we hope to bring you a real flavour of what it's like to be at a scientific conference, and particular to be at a scientific conference where people are talking about bones.
We're going to try and catch some of the award winners. There's lots of awards given out for some really wonderful research at the conference. We'll try and get some young investigators on, and we'll try and get some time with the big profs so they can tell us why they come to ECTS and what they get out of it.
And from my point of view, primarily as a clinician, what I love about these meetings is that there are clinicians and scientists together talking about bones, talking about treatments, and trying to work together to do their best for patients. I find these meetings very sort of stimulating and productive from that point of view. As a scientist, I hope you enjoy speaking to clinicians as well.
I love talking to clinicians. More importantly, at these conferences, I have to listen to them, because for me to deliver research, for anybody to deliver research which is going to be useful in the clinical field, you really have to start by listening to the clinician and finding out what the problems are, and then trying to think about solutions for problems. Lots of researchers, I think, they come up with solutions and then afterwards they go and try and identify the problem, and that's absolutely the wrong way to do it. And these conferences are just a kind of one-stop shop for what do we need to do and when do we need to do it by.
And ultimately then, smashing our brains together, what we're trying to do is to get better outcomes for patients, particularly for patients for osteoporosis. But at a big conference like this, we get to hear about all sorts of other rare and interesting bone diseases as well.
Yeah, we're going to hear about Paget's disease, we're going to hear about osteogenesis imperfecta, lots of interesting topics to cover.
Fibrous dysplasia, osteomalacia, lots of things on the agenda.
Yeah, and we're looking forward to it. Let's get started.
Let's go.
We're really lucky to have Kate Ward with us. Kate, how are you doing?
Very well, thank you. It's really good to see you guys again.
A friend of the podcast.
Absolutely, third time.
So this year, the ECTS and the BRS came together for one big joint conference. How did that come about?
It came about, we actually started discussing this about 8 or 9 years ago. So the two societies previously met together in Glasgow in 2010, and then we decided to try and get together again and started discussing it. And as with all of these things, it's taken quite some time to push through. It's taken a lot of tenacity and determination, and we eventually, post-pandemic, managed to book Liverpool and get the Congress together, which has been an absolute delight. It really does feel like the end of a very long journey, but I think both societies will be delighted with the way it's gone. I think Liverpool's been great.
Yeah, Liverpool is a fantastic city. The setup here is really nice with the hotels around us. I know people have been ducking out to go to the Tate Modern down the road. There's a real nice vibe about Liverpool. I like the place.
Yeah, it really is. I think that's what attracted us to the city. I think obviously the history of the Beatles as well, and of course the science. You know yourself, the bone and the anatomy that Jim Gallagher worked so hard on in Liverpool University, and so having him as the chair of the local organising committee and working together with him has been absolutely great. And this place is wonderful and not too disrupted by Eurovision just yet.
We've talked to you before about some of the work you've done, and you're presenting on a number of different subjects here. Would you like to tell us a little about maybe the poster you're presenting later on might be of interest to our listeners?
Yeah, sure. So this is, as you said, I've talked to you before about our work in Africa, and the poster describes the prevalence of osteoporosis and osteopenia across 7 cohorts. So 1 in the Gambia, 2 in South Africa, 1 in Zimbabwe, and then Health ABC from the US and Hertfordshire cohort from the UK. And the real reason for doing that was just to start to see, using our DEXA data, which are really unique across all of those cohorts, whether they're rural, whether they're urban, whether they're low-income country or a middle-income country, what does the actual profile of disease look like? And so that's essentially what I'll be describing. And in actual fact, the prevalence of osteoporosis is fairly similar to the Health ABC white women. So these are all our cohorts in Africa are black African men and women. So we have a similar osteoporosis prevalence. Men, not so much, but we probably wouldn't expect that. And I think the real key message from the whole poster is that we mustn't ignore musculoskeletal diseases in these areas. We're building the data now, we're getting fracture data. I've not presented it here, but the prevalence of fractures in our Gambian cohort, for example, is about 25%. So we're seeing similar prevalences to elsewhere across the globe. But healthcare is very stretched and resources are stretched. And as the population ages, they're going to get more and more stretched. So it's really a call for prioritisation of that area across sites.
You're very busy at this conference. You've also got a talk as well. Could you tell us about that?
Yes, I can. So this is a calcium supplementation study of mums in the Gambia. So this was actually run by Professor Anne Prentice in Cambridge back in 1995, and she supplemented women who were pregnant with 1,500 milligrams of calcium, which you'll both know is a similar recommendation to that we give here. And we then followed their offspring up for 21 years. And so I'll be presenting the data on the growth of the offspring and the blood pressure of the offspring. So the main message of the main trial was that calcium supplementation didn't reduce preeclampsia rates in the mums who were given calcium. But what we've seen is that bone growth and height growth is slower in the girls whose mums took calcium, whereas the boys grew faster. And the blood pressure in the girls whose mums took calcium is actually lower. So there seems to be a blood pressure effect, but it's intergenerational. It's happening in the children rather than the mums. So it's a complete puzzle. Everybody looks at me like that, Richie, when I talk about it. And of course, I don't have the bone data to present here, but that's what I'll be talking about tomorrow morning.
Doesn't it highlight the fascinating links between the cardiovascular system and the bone system, which we hear more and more about?
Yeah, I think it absolutely does. I mean, at the time, it was looking, as I said, to look at reducing preeclampsia. We've reported the bone effects in the mums before, and I think it is a puzzle, and it does have consequences because the WHO recommend that in populations with low calcium intakes, women should take 1.5 to 2 milligrams, 2 grams of calcium a day, and of course our population is one with low calcium intakes.
And that will sound a fairly high dose to some people, or a fairly high recommendation. And as you say, there are people in sub-Saharan Africa, they do have quite low intakes now. Is there any adaptation to low intakes, do you think?
Well, I think there must be, because the populations are habituated. There's very little dairy consumption, although that has changed since this trial was run. But very little dairy consumption. We still see in our Gambian cohorts, in our Zimbabwean cohorts, calcium intakes are in around 300 to 400 milligrams per day, that's very low for our standards. But so there must be an adaptation, because as you know, calcium is such a vital nutrient to everybody's system. if they didn't adapt, there wouldn't be survival. So there has to be that adaptation, yeah.
So I suppose my next thought would be to sort of conduct some sort of dose range trial, because 2 grams seems quite a high dose for someone who might be used to 300 milligrams.
Well, yeah, that's very true. And I mean, there are other studies. So there have been some in the US and Argentina that have also looked. I'm not entirely sure of the dose, but they've still found these offspring effects or differential offspring effects. I think the difficulty is that there's a necessity to give a recommendation, but there's certainly, I think, a caution to applying that recommendation. Now, our population is homogenous, it's rural subsistence farming, and that's the argument I'm always given, but I think all of our data from the Gambia shows that there's caution against not testing in the specific context.
Wow. It's, the findings seem confusing, but it's when you test hypotheses and you don't get what you expected that very often you actually come across the really big discoveries.
Absolutely.
So
absolutely.
It's simultaneously really exciting because clearly you're going to be able, if you can push it through, we're going to understand something about something new, something really novel and innovative.
And I think, like you say, I think that adaptation, there must be something. We've not found anything in everything we've measured. We've found some IGF differences in the offspring, but nothing with PTH yet. We don't have hormone markers. Someone the other day suggested looking at interactions between PTH and estrogen, but yeah, who knows? We'll keep looking.
Fantastic, and we'll follow up with you about it again. Thank you very much.
Thank you
Great
very
to speak
much.
to you again. Thank you.
Cheers.
We are here at ECTS 2023 with Professor Celia Gregson, Head of NOG. You gave us a wonderful interview on the podcast a few weeks ago. Thank you very much. I hope you enjoyed it.
Pleasure, yes. It was interesting to listen to.
How have you found ECTS this year?
Fantastic, yeah. A really good array of talks. Quite a lot of detailed clinical talks, which have been really, really interesting.
What have you learned so far this year? I learned that chemocytes are more beautiful than chondrocytes.
And what was your evidence base for that?
An eminent speaker said it in her talk yesterday.
Yeah. A few talks on Paget's disease. Paget's disease was one of those conditions that we thought had disappeared and yet is popping up at the conference all the time.
Yeah.
Why is that?
Well, I don't know, but there was a very interesting talk on Thursday at the Rare Bone Disease, but that was actually at the BRS, around Perthes disease, and also saying essentially we don't know what the fundamental etiology of that is, but it certainly is affecting more deprived communities in the UK, but its incidence is coming down very similarly to Paget's disease, was pointed out by somebody in the audience. So, yeah, interesting that we have these diseases that have been around a long time, and we still don't know actually what's causing them.
It's one of the fascinating things about bone, isn't it? There's still so much to be discovered.
Yeah. Do wonder about an infective underlying cause.
So I'm looking forward. There are a number of talks to come today and tomorrow on Paget's disease, and hopefully we'll be able to grab some of those speakers, maybe Richie, and ask them harder questions.
In Manchester, isn't there? That follows on after
That's
this.
right. Yeah.
Celia, what are your highlights, do you think, of the next few days?
Well, obviously, I'm going to be talking about the REDUCE study on Tuesday, so that's a highlight. I think that the debate actually last night around vitamin D trials and whether or not there's a necessity for more vitamin D trials, I thought that was a really great debate. Two really articulate speakers and who obviously know each other and are very good friends, and so a very respectful argument. But I thought that was a really interesting discussion, actually. And I thought what was important was to think about maybe not more trials in high-income settings of the use of vitamin D in older community-dwelling populations. I think the House has seen enough of those. But I think we don't know about other populations in the world, and particular disease groups For example, kidney disease, I was thinking of HIV while they were talking. I mean, we don't know about the role of vitamin D in those populations. So I think it's more focused trials that might be necessary rather than more of the same sorts of trials as we've already seen. But I thought it was a really interesting discussion. That was a highlight.
I love the debates. I feel they're always a highlight as well.
Yes, but it was done so gently.
It's refreshing
nice
to see proper academic scientific debate when so much debate in the public domain now is just people shouting at each other, particularly on social media. It's nice to hear people actually listening and debating and engaging on an academic level properly.
And accepting when a point is a valid point against their argument. I think, it was good.
Thank you very much.
Thanks.
Okay.
We're here with Qasim Javed. How are you doing today?
Oh, very good, actually. A little bit less tired than yesterday. I think I'm getting used to the rhythm of the conferences.
It is a long conference, isn't it?
It is. I've never had it back to back. We've got three. We've got the Bone Research Society, the ECTS, and then the Paget's meeting. So it's a marathon.
Thanks for making the time to speak to us. Can we call you a friend of the podcast?
Of course you can. I'm looking for my third mug now, as you know. Third mug.
So tell us a little, I mean, you're one of the big names here. You're speaking. Tell us about sort of, what we were talking about earlier there, the talk you're going to give later on.
Yeah, so I've been kindly asked to just give an update on my perspectives on denosumab, and it's the beauty of the ECTS is there's just a wealth of science from different disciplines, and as we were talking, from around the globe, not only Europe but also outside of Europe, and then give how I've applied that and how our region has applied that for patient benefit. So how do we translate that? And we were just talking about, what happens if you have denosumab therapy, when do you stop? What about atypical fractures? And you brought up the really important point that actually our main purpose is to prevent fractures. And if you do any math, the prevention of fractures by staying on therapy will always outweigh the potential risks of staying on therapy or of coming off therapy and facing, a rapid reduction in bone mass.
So we know that if we keep patients on denosumab indefinitely, thousands and thousands of patients, some of those patients will suffer atypical fractures. But should we be prepared to swallow that and to be upfront with patients about that because of the benefits of staying on it in the long term for most people?
That's a really good point. So I think you've hit the nail on the head. It's what the patient wants. So I've had a shift. We tend to give denosumab now to older patients. We're not faced with like 30 years of therapy.
Yeah.
But I have some younger patients who have low bone density, and I explain the issues. And they simply come back to me and say, Dr. Javed, I just want to be fracture-free for the next 10 years. Am I going to get that level of adherence with oral bisphosphonates? Probably not. I want my bone density to keep increasing. And we sort of maneuver our way through simple questions and answers, and they then make the choice, actually, I will take denosumab, and if it's a long-term therapy, it's the long-term condition.
So if we get to 10 years, that's a discussion between you and the patient if we continue, and if the patient wants to continue, then that's something we should be prepared to.
Definitely. And we know the biology a lot better now. We don't know the exact mechanism of the off effect, but we know a little bit more about how it could work, and that will be the challenge of patients who definitely need to come off for very few indications, severe renal failure, they're getting hypocalcemia, then you've got to think of an exit strategy.
And we're swapping at the moment one anti-resorptive possibly for another if we're giving IV zoledronic acid. Does that make sense to you?
It does because of the duration of action, but it doesn't in terms of the mechanism of action.
Yeah.
But there's a poster here that showed weaning denosumab doses doesn't actually lead to bone loss, which is actually quite exciting. It might be that actually we have a dose option in getting people on who've already maybe achieved skeletal benefit, weaning them off. But that needs more studies, needs more analysis, but that's why it's so exciting at the ECTS. There's so many new ideas that are coming. I never would have thought of using 15 milligrams of denosumab. That would have been an anathema to me. But you see other bright people bringing it up.
Yeah, maybe we should be adjusting doses more for so many of the drugs we use, shouldn't we? Which is so analog. You either get 70 milligrams of zoledronic acid or you get none, and that we should be adjusting doses. That's
a good point. In Japan, they have a completely different approach to dosing for all the anti-osteoarthritis medications. And I think the other elephant in the room is the indication. Are we using the same dose for severity of disease, but also for different disease indications? And denosumab and other agents are being used in lots of other conditions, and we tend to stick to the doses we have, which doesn't quite make sense.
Sorry, we're having a clinician's discussion here, Richie.
This is really interesting. I'm sure the listeners are going to love to hear this kind of inside track on the treatments and the dosages and the regimens. I have a question for you both, actually. How important are conferences like ECTS for clinicians to build a consensus around how to treat your patients?
I think it's really important because on two broad levels, I suppose. It's for the new clinician who isn't quite sure. Reading the papers is one thing, but actually hearing someone present the data and then critically the type of questions that are asked can really upskill the clinicians from moderate to really expert status. So it brings everyone up to the same level very quickly, more than you'd get by reading the paper. And then for those who want to push the field further, like I've said, you can bring new ideas forward and think of new studies, new ways to analyze the data. People will critique what you say and you think, actually, you haven't thought about it like that. I need to go back to the office and do that. And I think it's that beautiful, not aggressive in a bad way, but aggressive in an intellectual way of saying, this is what you've shown me. I don't think this and this work as well as that, and that. And it's that sort of freedom we have in these conferences to really understand what's going on that pushes the field forward on so many levels.
There's a great freedom in face-to-face discussion.
Yeah.
I don't think you and I could maybe write a paper about what we've just discussed earlier, but we can talk about it face-to-face, and that's what moves the discussion on, isn't it?
Exactly, and as I said, people will say, oh, we heard you talk at this meeting, we're setting up a working group, can you come and join our working group? And although we are now digital, we still need that face-to-face to actually rapidly understand what our knowledge is, what my knowledge is, and then see where the uncertainties are, and then push it forward. It's much better face to face. And of course, the food is pretty good, and the drink is also useful.
Thank you very much for talking
That's
to
great.
us.
Thanks for taking the time.
Oh, do I get my mug now?
Oh,
That's fantastic.
thanks.
Hi everyone, we're here with Ralph Oheim from Hamburg. Nice to meet you.
Hello, nice meeting you.
You gave a fantastic talk which we saw today about iron in the body. Could you tell us about it?
Actually, it's a very, very interesting topic, but not well understood yet. And so I was asked to give a talk because we followed some patients with hemochromatosis and their bone manifestations. So, and of course, if you are invited to give a talk, then you're happy to do so. But it's a very complex issue, and if you get into it and if you read a lot of papers, then you are just realizing how complex it is. And so yeah, actually, I'm lucky it's done.
People like maybe simplistic explanations for things, but in terms of iron, too much iron is bad for your bone, and too little iron is bad for your bone as well, isn't that right?
Yeah, it's completely right.
So how do you, here's an easy question, how do you explain that?
I mean, iron is like very tight regulated, and of course it's like with many other nutritions or supplements. We need just the right amount of it, and iron is if you are not having enough and you have anemia, for example, then of course not only the bones but just all the other organs suffer also. But especially the iron overload is an issue in disease, and that's why we have there's no mechanism in that our body can get rid of iron, so you are not excreting iron. So phlebotomy is the method what we use to in hemochromatosis, but otherwise there's no specific way in losing it.
And am I right in saying that the effects of too much iron in the body, hemochromatosis, it's not just reflected in low bone density, it's reflected, it damages bones in other ways, is that right? It's quality of bone as well?
Absolutely right. It's not just density, and density is like two-dimensional. Of course, it's structure, it's metabolism, it's so affected in so many ways, and we are just beginning to understand. We know already, there's good evidence that iron and the oxygen subjects, reactive oxygen subjects, do have an effect on the osteoclastic lineage. But yeah, we are just at the beginning.
So if somebody has too much iron in their body, is there a treatment that can reduce the iron levels?
Now you can, basically, in hemochromatosis, you do a phlebotomy, so blood loss is an effective way to get rid of iron. And the other way is chelators, to use substances that bind iron, that you are not absorbing more iron for your diet, and of course low iron diet, etc. These. Otherwise, it's really hard.
We've been talking about too much iron. I think it's generally well known that to have too little iron, to be anemic, is also bad for the bones. But you were saying today that when you get regular iron infusions, and many of my patients do come up and get regular iron infusions, that can actually be bad for the bones. You get high levels, what was it, FGF23, low phosphate, and you get, I don't like to say damage to the bones after an iron infusion, but getting iron infusions can be bad for the bones, is that right?
That is right, whereas we have to say that there is a reason for getting iron.
Yeah.
And of course, you have a disease, you have anemia for different reasons, and you want to treat the iron loss or the deficiency, and that's why you need iron infusion. That's no doubt about it. However, there are specific IV iron substances that do exactly what you mentioned, that they interfere with the FGF23 metabolism, resulting in increased intact FGF23 levels. And this can lead to hypophosphatemia, and if hypophosphatemia persists for a long time, you can get osteomalacia, so the mineralization disorder of the bone. And then that is something really patients can be symptomatic with, but these symptoms are very unspecific. So muscle pain, bone pain, insufficiency fractures, something like this. Yeah.
So I'm not suggesting you shouldn't be getting the iron infusion. I better make that clear. But we're just saying we're learning about these things, that actually regular iron infusions may upset bone metabolism.
Yeah, exactly. And actually, hypophosphatemia is an official box warning in these substances. So just you have to look for it. And there are many patients are fine with their IV iron, but some get hypophosphatemic, and some of these get osteomalacia. So we have to check it. Yeah.
The relationship between iron and bone health seems to be quite overlooked. The chair in your session at the end said this might have been the first time you've ever had talks about this at ECTS. Why do you think it's such a neglected area of research?
Well, that's hard to say. I think some of the diseases, the patients are very badly affected. So no one was really actually wondering why these patients do have secondary osteoporosis, because they are just very, very ill. And then just with the second, third look, it came out it's the iron itself that's doing harm to the bone, also in addition to all the other endocrinopathies, etc. So, but looking forward is that we have it now on the map, and we're taking care about it. And as we said, like this whole issue of iron and hypoxemia, there is a huge need of investigating this issue and how it works on tissue level, etc., etc. So we'll see a lot of interesting stuff.
Should all patients with hemochromatosis be assessed for bone health then? Should they be getting DEXA scans?
Yeah, adults should, actually. And most patients get symptomatic between 30 and 40. And it's much easier to monitor them early and to treat them early than to deal with the complications of the secondary osteoporosis or the fragility fractures. So yeah, screen them early.
So that's a message for my gastroenterology colleagues who I know all listen to the podcast.
Sure they do.
Ralph, thank you very much for talking to us today.
It's been really good. Thank you.
Thank you.
So we're very lucky to have Emma Clark with us. Emma, how are you doing today?
Yeah, I'm very well, thank you, Richie.
Are you enjoying ECTS this year?
Yeah, very much so, actually. I haven't been for a couple of years, and again, I'm just really struck by the variety. I really like the mix of basic science and clinical and orthopedic surgeons and rheumatologists and basic scientists. It's great.
It's what we were talking about earlier, just it's so exciting that people from different aspects of the bone world get together, all working for the benefit of patients, and you get so many ideas bounced off each other, don't you?
No, I agree, and I like, the way the posters are arranged. You haven't got clinical at one end and basic at the other. It's all mixed together so that you do get a really good sort of cross-pollination, and you can get so many different conversations as you walk through. It's great.
And so what's some of the point of coming to a face-to-face conference is meeting people at posters, isn't it, and talking about things and saying, well, that's interesting because I used to see a patient who, and which you don't get over Zoom.
Oh, definitely. And particularly when you have a session like this lunchtime where people are standing outside their posters, you walk along and you make the mistake, or perhaps it's not the mistake, of catching someone's eye, and then you feel obliged to ask them, and then you realise it's amazing. Yeah. It's really interesting. It does broaden your horizons.
It's really important for the young scientists here. I remember when I was young coming to my first conferences and presenting posters. It's great when people walk by and start asking you questions and you get to talk about, you spend so much time in a lab doing your own little thing, you kind of forget there's a bigger world out there, and it's so wonderful to share it with people. Yeah,
definitely. So I've got my junior researchers here. She's on a PCAF scheme, which is a preclinical scheme prior to a PhD. It's her first poster at a conference, and she's just stood there and her knees are trembling and she's loving it. People are coming up to her and she's writing down the answers and the questions, and she's just really excited and a bit buzzing and knowing what she's going to do differently next time, and it's great.
When you're in the middle of your research, you're so scared coming to conferences that people will ask you hard questions, and you forget that you probably know more about your research than anyone else in the world, probably even more than your supervisor, regardless of what your supervisor pretends.
No, I agree completely, yeah.
I think it works the other way. I want the really, really hard questions, because that means that the people in the audience are spotting the flaws, the problems, the inconsistencies in your work and telling you. And that means they're doing your job for you, and it makes your research easier in the end.
Definitely, and you can't possibly assume that you know everything about your research, and people will come at it from different angles, from different specialties and different backgrounds, and it just makes it much more rich, I think. Yeah.
Anything you've enjoyed particularly? Anything you're looking forward to particularly?
Well, I'm going in a minute to the management of atypical femoral fractures and how we treat them afterwards, because that's something that scares me. So I want to know what other people are doing to just see if I can get any other suggestions.
That sounds like a good one.
Yeah.
Thank you very much, Emma.
Thank you. Thanks for speaking to me. Bye.
Listeners, we're very lucky to have Richard Keane with us. Welcome to the show.
Hi, nice to meet you.
So, Richard, you've been studying rare bone diseases and you've got a presentation at the conference. Would you be able to tell us about it?
Yeah, I've been studying fibrodysplasia ossificans progressiva, which is a pretty long name. It's FOP in abbreviation. As it's a really devastating disease. It affects about 1 in a million individuals, where basically bone starts to develop in places it shouldn't. But what's really exciting is that there are some trials that we've been involved with, looking at sort of drugs that might slow the progression of this disease. So the presentation I'm going to be talking about is a drug called garetosmab, which is a monoclonal antibody against activin A, and it seems to reduce the number of flare-ups these patients get, so stops the bone forming, and therefore we're hoping with long-term it's going to sort of have an impact on improving their quality of life.
Wonderful.
We were speaking to Gonzalez earlier just about FOP, which will perhaps make it sound more common to our listeners than it actually is. With rare diseases like that, there's sometimes a focus nowadays, do you think, on getting to the genetic cause and on a gene treatment for the disease? It's interesting that you're looking still at a monoclonal antibody at actually treating the outcome of the disease rather than getting to the genetic cause of it.
Yeah, I mean, the gene for this disease was only discovered about 17 years ago. So, I think that opened up understanding the pathophysiology. So at the moment, yes, we're still using drugs in the pathway of the condition. But I think with the advances that are going on with genetics as well, some sort of gene therapy is also is something that will be looked at. But at the moment, just by understanding the biology, we've identified a number of potential targets of drug treatments. And there's actually, I'm presenting on one of the trials, some of the data, but there's at least another 2 or 3 trials sort of in phase 2 development already, so which again is really exciting for the patient group.
And will these, and again I'm always thinking of the 1 or 2 patients I have in my clinic with unusual diseases like this, will this reverse the process that's happened, or will it simply stop it getting any worse? Because that's the first question I think people ask.
Yeah, I think these treatments are at the moment they look like they're just going to stop the progression. But again, I think if we've got treatments that actually do that, then for some of the patients that already have quite severe disease, there may be the possibility of doing a surgical trial whereby you could release a fixed joint and then give them the drug afterwards to prevent it sort of refusing.
That's exactly what I was thinking, because I'm thinking of a patient who has even minor surgery and has huge overgrowth as a result of it. But if we could give this drug and then they could go for surgery and
exactly.
not see that reactive bone growth.
Exactly, because I just think for the patients that already have this disease, that it's impacted an awful lot on their life, and so I think that they need something that's going to hopefully improve matters. And at the moment, the drugs don't look like they'll do that. But surgery with then a drug afterwards is another goal of what we're trying to do.
A lot of the more common diseases like osteoporosis have got multiple therapies available for the patients. Is there more of a shift now to try and develop medicines for people with rare diseases?
Yeah, there is. I mean, I think, again, our understanding about these rare diseases, both, I understand the genetics and the biology, but also we know from, some of the drugs we're using in osteoporosis, actually understanding the sort of biology of rare diseases has then led on to drugs for osteoporosis. But I do think we're at an age now where some of the rare diseases which weren't being offered any treatment at all, we're now in a massive explosion of new treatments, which is great, because again, as a doctor myself, when I look after a lot of patients with osteoporosis, but again, the rare disease community has been forgotten for a while, but I think we're on a really good trajectory with new treatments.
I think we're going to have to get you back for a full episode so we can explore the rare diseases in more detail.
I'd be delighted to.
Wonderful.
That would be great. We'll even give you another episode mug if you do.
That's even better.
Thank you very much.
Thank you.
Thank you very much indeed.
We have a new guest with us. We've been talking on Twitter. Would you tell us who you are and where you're from?
Yeah, I'm Gonzalo Sanchez Dufus, actually. I have a mixed background. I'm originally from Spain, but I'm half Dutch. And I've been in the Netherlands for the past 12 years doing research. And now I'm actually, since January 1st, moving back to Spain to have my own lab over there.
Oh, that's exciting.
Yeah, well, and scary too.
So tell us what you're presenting here at the conference.
Yeah, so I'm a biochemist by education. I basically focused on T-beta signaling and rare diseases where T-beta signaling is mutated. And of course, one of those rare diseases is fibrodysplasia ossificans progressiva. It's an ultra-rare disease where patients develop a second skeleton in response to inflammatory damage. So what we found is that by repurposing drugs which are already in the market for the treatment of cancer, for example, one of those drugs was effectively inhibiting bone formation in mouse models of FOP, and also in IPS derived from FOP patients. Yeah.
Wonderful. What do you mean by second skeleton?
Yeah, well, what this it's a kind of devastating disease, but at the same time fascinating. So these guys, well, it was back in 2006 that it was identified that all patients carry exactly the same single point mutation in one gene, right? And this mutation turns on the T-beta pathway in response to inflammation. It has been found out that it's like specific fibrodipogenic progenitor cells in the bone tissue, in the connective tissue actually, that become osteoblasts in response to inflammation. So that starts affecting connective tissue like the ligaments, the fascia, the tendons. So eventually they would get imprisoned. So mobility is compromised very quickly. Their jaws get fixed, so they show nutritional problems because they cannot eat properly, and I think they're normally by their 30s they are wheelchair bound, and they die around by their 40s.
So this is a rare disease where people's soft tissues essentially turn into bone and sort of become, as you were saying, almost like a second skeleton. It has a very long name, but we call it FOP when we're talking about it here at conferences. It's rare. How common, maybe this is an unfair question to just drop on you, how common is it? How many people, let's say, in a European country would you expect to see with FOP?
right now, well, when I started working on that, like 12 years ago, the prevalence was meant to be 1 in 2 million. But nowadays it's 1 in 1 million. And that's mainly because of the great effort that has been made in awareness. So the only symptom that babies have when they are born with FOP, it's a great toe malformation, so this hallux valgus. And nowadays we can diagnose with a genetic test, but usually when these kids go to the hospital, pediatricians, they think of tumors, so they try to resect it. And when you resect it, you induce inflammation, which causes a relapse. And so nowadays, basically, I think it's a matter of diagnosis and awareness that we are now in 1 per 1,000.
And
1 million.
If we're screening for any condition, the question always is, well, is there effective treatment if you screen for a condition? There's no cure for it at the moment, but there are ways of managing it.
Yeah, so traditionally what we have been doing is to basically apply cold packs and broad spectrum anti-inflammatories, because somehow it has been reported that the patients can sense when a flare-up is coming. It's not always true that a flare-up becoming an extraskeletal plaque of bone, but this has been the treatment or the way to manage the disease. Of course, once a kid is diagnosed, then you take special care of its physical activities, and be aware you cannot, for example, bike like anybody else, because in case you fall, be aware you cannot play soccer, but these kind of things. And I think we have nowadays we have a couple of drugs in clinical trials that look very promising. Major concern is that, when you play, you don't want to mess up with the T-beta signaling pathway systemically. That we got to know from cancer studies. So whether those studies will result in a drug that it's effective but at the same time safe, it's still a concern.
And as we often say with these rare diseases, we sometimes learn things about how bones work that we can apply to maybe more common diseases. That's really interesting.
That's my research line.
Wonderful research. Thank you very much for sharing with us.
You're very welcome, and thanks a lot for the invitation.
That's great. So our next guest, this will be interesting. It's one of Richie's postdoc students who's going to tell us a little about her work and a little about maybe what it's like to work with Richie. So introduce yourself if you don't mind.
Hi, my name is Dahlia, and I work as part of Richie's group to understand collagen mineral at the nanoscale. So I work mainly to sort of interrogate the structure of bone at that scale using various electron microscopy techniques. I also want to interrogate the molecular sort of interaction between collagen and mineral using spectroscopy.
Okay, so patients I see, they're told as they get older that the amount of bone tissue they have goes down. You're looking at the quality of bone changing as well.
Correct.
Is that right?
Yeah. So
and what do you see with your scanning electron microscope or your?
So far, we've been doing some cryo SEM, so cryogenic work. So we're able to visualize the bone tissue hydrated. And some of our images have shown that the older femurs have more Haversian systems and in the transverse cross section of the tissue, and we believe it's linked to higher rate of bone remodeling with age.
Okay.
And we've also seen with the spectroscopy that the older femurs have lower collagen content, and it might be possibly linked to the fact that the structure is, because of there's a remodeling sort of situation going on, that the structure is transitioning, and therefore these bonds aren't as readily formed because of the fact that it's a changing system.
And have you been able to look at people who've been treated to slow down their bone remodeling as compared with those who haven't?
No, not yet. No, we haven't had a look at that just yet.
It's a good idea, though.
Yeah, for sure. Yeah.
See if maybe it restores or reverses the changes.
It strikes me that some patients, you probably know this, we give them what are called anti-resorbatives, which slow down bone turnover and remodeling.
Yes.
Some patients with very bad disease, we give them anabolic agents, which actually stimulate and increase bone turnover for a period of time.
Right,
So
okay.
that might be interesting to look at with the electron microscope to see just what's happening.
Definitely. I mean, we just saw a talk 2 hours ago about the combination of using anti-resorbative sort of treatments along with anabolic treatments and the effects of those. I'm not too sort of practiced on the effects of the drugs necessarily, but it would be interesting to sort of see how that would look visually and what happens to the bone tissue at the nanoscale and the microscale and even like molecularly.
You always get these amazing images when you use electron microscopy.
Yeah.
How does that translate, or do you think it would eventually translate to something that I could use at the clinic?
That's an interesting question.
Because you use bone from people who've had the hip replacements, is that right, mostly?
So it's a combination of both. So it's that and cadaveric tissue as well that we use.
So it's not living. It's not living bone. It's not bone in a human being. It's bone that has been removed or from a human who's died.
Yeah. So, I guess clinically, we're trying to understand if there's maybe a potential sort of way to target like molecularly, like a link between collagen mineral, because obviously that's what gives bone its integrity, the synergy that exists between these two sort of components. So it'd be interesting, I guess, to sort of understand scientifically what happens with age, I guess, or with disease, and hopefully that could translate in a clinical setting where people might try to use these as targets for potential treatments maybe. Yeah.
And finally, what's he like to work with?
Richie's great, yeah. He's great. He's very supportive, very hands-on, and it's great to work with Richie for sure, yeah.
He realised he edits this.
Oh, okay.
It's really great working with you as well, Talia.
Oh, that's great.
I think this is a really good example of the bone world reaching out a bit to bring in people with really good skills and knowledge of new technology to come in and then start adapting and developing that technology to learn new information about bone structure at a very small level, which is going to be really relevant for fractures and aging and disease. But at the minute, we know very little about how bone structure changes at molecular and nano level, let alone what that does to the bone or whether or not there's any targets there for treatment and diagnosis. It's an exciting project.
Yeah, for sure. I mean, there's very little, like what Richie's saying, very little literature out there about what happens at that scale, at the molecular scale. Nobody really understands what's going on. So it might allow for sort of like potential, like I was saying, like treatments, or just to understand that what we're targeting is maybe something, or what we need to target, is something a bit deeper than just the surface level. It's actually down to like the atomic scale, but we'll see.
It's really bone up.
It really is. Thanks very much, Della.
No worries. Thank you for having me.
We're lucky enough to have Kevin Ochran with us. How are you doing today, Kevin?
Yeah, I'm doing well. I'm excited to be here, and I'm excited you have me on your podcast today.
Oh, wonderful. Thank you. Have you been to a conference before, or is this your first one?
I've been to a conference, but this is my first ECTS Congress. Yeah, and it's a nice atmosphere. Everybody here is lovely, and I'm actually learning a lot of cases to see, and a lot of insight to learn. Yeah.
And I understand you're a PhD student. What's your research about?
Okay, I'm a PhD student at Leiden University Medical Center, and I work on bone complications after liver and kidney transplant. And of course, the outcomes you expect is fractures, but we try to study osteoporosis and any sort of bone decline and bone turnover markers in the middle. Yeah.
So after patients have the liver or kidney transplant, they're probably very focused on the liver and kidney, and the problem is they maybe have a fracture 6 months later.
Yeah, so most of the time the fracture happens in the first 3 to 6 months, but of course the first year is the most intensive. And for example, the glucocorticoids, it does decrease bone formation during the first year, and then in the second year it does also increase bone resorption. So of course the first 6 months, 6 months to 1 year is when we really pay attention to these patients.
And can we do anything before the transplant to make it less likely the patient's going to have a fracture after the transplant?
Okay, so for example, we do assess the patient's bone mineral density, and if it's really low, we can give bisphosphonates to improve the bone mineral density. And also, when it comes to calcium levels, PTH levels, vitamin D levels, we can give some sort of supplements before the transplant happens to improve, these markers to help reduce the patient's risk for fractures.
So tell us then, you mentioned both liver and kidney.
Yeah.
I see patients with kidney transplants who've had very low bone mineral density for years, and when they get the kidney transplant, often their bones recover quite well.
Yeah.
I'm always educating my renal colleagues about this. What happens after a liver transplant? Do the bones recover spontaneously?
Okay, so with that, it depends on a lot of things. It depends on the pre-transplant factors. For example, the type of liver disease determines the outcome also. But then, if the patient has low bone mineral density, if it's below minus 2.5, it depends on whatever hospital it is and what kind of guidelines they are following. But ideally, I always say that if the BMD is below minus 1.5, I think everybody should get bisphosphonates to improve the BMD and to reduce the fracture risk. Yeah, so of course, if the patient has some sort of low BMD, we can give bisphosphonates to improve the BMD and also, reduce fracture risk. But it depends. Sometimes it works, sometimes it doesn't work, based on the factors present in the patient,
Why are people with liver or kidney disease at higher risk of having a fracture? What's the mechanism?
It's complex. It's multifactorial, but I'm going to try to explain. Not the pathophysiology, but a bit of the mechanism. So I can only paint a story to you. So for example, you have an alcoholic patient. Alcohol itself affects the osteoblast and osteoclast. And most of these patients, they are high on alcohol and stuff like that. And once the liver gets damaged, it can't, for example, it can't really absorb vitamin D. It can't really, for example, collagen synthesis and stuff like that. It gets affected. And so that plays a role. Vitamin D levels get low, PTH levels get affected and stuff like that. And it's start before the transplantation. While the transplantation happens, you give glucocorticoids for immunosuppression, and that also has an effect on bone formation and bone resorption. And
So the thing that has caused the liver disease has also damaged the bone?
Of course. Alcohol is really toxic to the bone also. So it happens.
We shouldn't tell that to conference goers.
Yeah.
Kevin, thank you very much for talking to us today. That was really wonderful.
Yeah, I appreciate being here.
That's great. Nice to talk to you. Thank
nice
you.
To talk to you. Yeah.
We're here now with Frederica Schulte from ETH Zurich. Welcome to BoneUp.
Thank you. Welcome also from my side.
I'm really excited to talk to you about your research. We looked at your poster earlier on and it seems very exciting. Could you tell us about the work you're presenting at the conference?
Yes, sure. We work on the effects, the combination between different treatments, anti-catabolic treatments or anabolic treatments, and an additional regional mechanical loading can have on the bone response. And we work in the preclinical field, we work with mice.
This is something very exciting. We love talking to people. We've been particularly excited looking at your work. What you're saying in the simplest terms is that if you exercise, it adds substantially to the benefit of most of the drugs you can get for osteoporosis, but some drugs it seems to add particularly. Is that right?
That's right. That's right. We looked at bisphosphonate therapy. We looked at PTH therapy and at anti-sclerostin therapy.
Okay.
And what we could see is that all therapies benefit from an additional mechanical loading. But the bisphosphonates, you see only up to 15% increase in benefit in improvement of bone mass. In PTH, you see an additive effect of 30%. And with sclerostin antibodies, if they are combined with regional mechanical loading, we get a synergistic bone response 40% more than we would have expected. No.
So to translate that into almost the language we use in the clinic, so the PTH is teriparatide injections. So anyone listening to this who's had teriparatide injections, and the anti-sclerostin antibody is romosozumab. And what you're saying is if you just take the drug, you get some improvement. But if mechanical loading sort of means exercising in many ways, we can talk about the different types of that. Did you get an additive effect from the drug? 15%, 30%, 40%, depending on which drug you take. those two drugs that you're getting maximum benefit from, those are both anabolic drugs. Is there something in that, do you think?
Yeah, we believe that they act on the same mechanism that is also used by mechanical loading. So bone, we have all drugs. They act on this cellular feedback system that allows bone to adapt to changing mechanical demands. And therefore, it was interesting for us to also evaluate whether they would act on the exact same mechanism, because only then we could expect an even synergistic response from a combination of the two treatments.
This is really exciting research. It makes complete sense that exercise is going to potentiate the effect of drugs or maybe work alongside the drugs. When you get these extra increases in bone mass of between 15 to 40%, what do you think that would do for the fracture risk reduction?
Well, especially for the sclerostin antibodies, for all therapies we can see, because we can visually compare whether the sites that are improved are really also the sites in need of strengthening, and we can see this, and we can also quantify this relationship. So this is there. The sites that are in need of improvement are tackled by the bone formation and are then improved, and therefore we expect also a lower fracture risk to be proven by clinical studies then later on. So we are.
You were showing us some lovely images earlier, which we can't reproduce in the podcast. You were showing me areas of bone that look weak, and those same areas after romosozumab, after exercise, those are the particular areas that get stronger, because people sometimes say, you're making new bone. Is it useful bone? Is it in the right place? You're showing that combination of exercise and anabolic agents, it's just in exactly the right place.
Yeah, I think that's the real benefit of the mechanical loading, that we add this stimulus, because this stimulus can indicate where the cells should act and where they should be recruited.
So one more question, if we may. Are you going to submit it to Nature or Science?
We can have a try.
Yeah,
it's really always try.
It's really, really interesting and exciting work. And from my point of view, that's really high science, but it's exactly the sort of question the patients ask me at the clinic as well. So really lovely to talk to you.
For the benefit of the listeners, David has a very broad smile. I think we found some research that is translating into his clinical practice. Thank you.
Thank you very much.
Lovely to talk to you.
Wow, David, we're only halfway through the conference and we've already had some really great interviews. What are your takeaways so far?
Yeah, there's so much to choose from. We've been hearing a lot, both the people we've interviewed and at meetings as well, about how other diseases affect bones. So we've heard about diabetes, about iron, about liver, about transplantation. That's always interesting, because at the clinic, you don't see patients with just one condition. You see patients with lots of things together. It's always nice to come to these conferences and hear about rare conditions as well. And certainly we spoke to a couple of people, Richard and Gonzalez, both about FOP. And that's always an interesting takeaway to go and think about that. I always enjoy having chats with my clinician friends, and certainly Cass Javed and I had an interesting chat about dosing and how we tend to use exactly the same doses for patients, regardless of their age, size, gender, anything else, and how perhaps in the future we could look more at more sort of personalized dosing. And I think you and I both sort of agreed that the last interview we had there just with Frederica about adding exercise to treatment was very exciting. Not only do you potentiate medicine by exercising as well, but it seems you potentiate anabolics rather than anti-resorbatives, which would make sense. And I think the very exciting thing and interesting thing, and the sort of thing patients ask me sometimes as well, is that we weren't able to show you the pictures, obviously, on the cast, but you could see how you were building bone in all the right places, in those parts of the body that were weak, in the neck of femur. So that was really exciting. Your body seems to know how to respond to these things. So so much to go away and think about, Richie. You as well, I'm sure you had a lot of take-home messages.
I've really enjoyed this conference so far. I think what I've most appreciated is how much good basic science and preclinical science there is. By the preclinical science, I mean the animal work that's going on. It's really exciting. I agree. I think Friederike's work was absolutely incredible. And I think that's a good example of this, where preclinical research is being done, which gives us a really good idea maybe of how the drugs are going to work in humans. So there's a translatable aspect for that. I'm really pleased to see so many people at the conference who are interested in bone structure and bone mechanics, which I find really interesting. And I'm looking forward to the second half of the conference.
That's great. We'll see you folks in part 2.